Thanks.
Welcome to today's conference call, New Look at Managing Falls. My name is Hilda and I will be your operator for today. At this time, all participants are in a listen-only mode. Later, we will conduct a question-and-answer session. Please note that this webinar is being recorded. And now I would like to turn the call over to Ms. Christy Wergien. Ms. Wergien, you may begin.
Thank you. Hello, everyone. This is Christy Wergien with Lake Superior Quality Innovation Network, and I'd like to welcome you to the webinar, New Look at Managing Falls. This webinar is intended for providers working with quality innovation networks in Alaska, Colorado, Hawaii, Illinois, Iowa, Kansas, Michigan, Minnesota, Montana, Nebraska, Nevada, New Mexico, North Dakota, Oregon, South Dakota, Utah, Wisconsin, and Wyoming. Because Metastar is providing continuing education credit for this presentation, we need to inform you that no commercial support has been received for this learning activity and that the speaker has reported no conflicts of interest and there are no planner conflicts of interest. For CE credits or certificate of attendance, you must attend the entire session and complete an online evaluation that you will receive at the end of this presentation. We encourage everyone to complete the evaluation to provide feedback on the session. All lines will be muted during the webinar. At the end of the webinar, there will be a short time for questions if there's time, and you may also ask questions in chat. We're pleased to have Sue Ann Guildermann as our speaker today. Ms. Guildermann has over 40 years' experience providing education, leadership, and consultation to not-profit and for-profit long-term care organizations. She's a registered nurse with a BA and MA in communication and adult education, and she currently designs and produces educational seminars and conferences at Impera, which is a consortium of 24 skilled nursing facilities and 14 assisted living facilities in Minnesota. For the last 8 years, Ms. Guildermann has created educational programs for both management and direct line staff to assist in the implementation of 2 consecutive 3-year national and state quality improvement grants. The purpose of these grants is to reduce residents' fall and improve the residents' quality of sleep in skilled nursing homes. In January 2012, Impera's Fall Prevention Program was awarded the Minnesota Commissioner of Human Services Circle of Excellence Award for contributions to the well-being of human services clients. Ms. Guildermann has edited, designed, and written education manuals, printed materials, and videotapes, and she's taught at the University of Minnesota in the School of Public Health. She was also awarded the Chairperson's Award for the Care Providers Association of Minnesota, so we're really happy she's here. Thank you very much for speaking with us today, Sue Ann, and I'll now turn the presentation over to you.
Thank you, Christy, and that took up way too much time. If I had known you had that long bio, that would have been the first thing I thought. But thank you for that, and thank you to Status Health for allowing me really to share the work of what I consider to be very courageous and risk-taking colleagues. I work for a group of people who are very forward-thinking. They are risk-takers, and that is how I am here today, because of their work. So I feel honored to represent the work that they are doing. What we're looking at today is a program, and I like the term a new look at managing falls, because one of the things Christy shared with you is that I have been a registered nurse for over 40 years, and I have worked primarily of those 40 years in the long-term care profession. I've been a director of nursing in a skilled nursing facility, and so I bring to this presentation that background as well and that experience. And so for me, this program that Impera was awarded by the Minnesota Department of Human Services is a new look at falls. And so what I'd like to do is share both the background of how we used to, and I know as I go around the country still do, try to reduce falls in a nursing home, as well as this new look at managing falls. If you will, Christy, please advance the slide to slide 3. Just for briefly, the objective, hopefully in 1 hour, I can focus on the utilization of root cause analysis in the investigation and prevention of resident falls. We're going to analyze the internal, external, and systemic conditions and operations that contribute to the causes of resident falls. And then we'll identify the appropriate interventions for reducing falls. Next slide, please. Slide 4 very quickly just says this is the definition we use in our 3-year program. We were measuring falls. That's key. And how did we measure falls was right out of the CMS RAI User's Manual, and that is the definition. And so just briefly to point out some, I think, key elements of this definition, and that is a fall is an unintentional change in position coming to rest on a lower surface. The other aspect is the fall is not the result of an overwhelming external force. I know that perhaps a resident can push another resident and that resident subsequently falls down. That's not measured strictly as a fall. It is an incident. It needs to be investigated. It needs to be reported, but it is not a fall. The next one is an intercepted fall occurs when a resident would have fallen had you not caught them. And that became a challenge for us because so many times when I was a nursing assistant so many years ago, we felt so good because we caught the resident, and I wouldn't want anybody perhaps not to do that. But nevertheless, if you intercepted a fall, that is still a fall, and that's what we were measuring. Next picture, next slide, please, slide 5. So what is the history of fall prevention, and how did we move or change away from that history? The history of fall prevention for me, and I think for most of my colleagues who've been in this field, is that you have someone who is at a high risk for falling, and you immediately think interventions. When I was a director of nursing, I knew that I'd be having a patient who was coming in, a resident who was coming into my nursing home, and if I was fortunate, I got a nice history from the hospital, though frequently it wasn't always complete, but nevertheless, I did the best I could to get a history from the hospital or from the assisted living or from their personal care attendant, and sure enough, within that history, that assessment, I would determine that that resident was at risk for falling. And I immediately went into the mindset of what interventions can I put in place to keep them safe. And so the first thing I would think is, oh, do I have a bed by the nurse's station? What about early on, restraints? Should I be restraining this person? Well, what about when they sit in the chair? Can I have a tilt cushion to prevent them from getting out of the chair? Oh, and when we started to reduce restraints, well, then we implemented alarms. So let's put an alarm on someone. And then, of course, if they began to fall down, there were those interventions in place at the time of admission, and sure enough, they came into my nursing home and they fell. Well, then we needed to put gripper socks on them. Oh, and let's put them in a low bed. And then let's put a mat on the floor. And so my career has been spent in the prevention of falls by looking at interventions. What this program did is took a different look at fall prevention. If you would, next slide 6. We said, okay, I did then what I knew then, but when I knew better, I did better. We used those interventions with the best of intention to prevent a fall. But they weren't working because residents were continuing to fall down. And falls still remains in many states in the United States one of the highest F-tag deficiency that we experience in our profession. And so I have to say, we're not doing a good job at preventing falls when we simply look at the interventions. So this program, this 3-year funded program, allowed us to take a different look. What we said is, let's look at what's causing the fall. Let's put those interventions on hold. Our focus for this program is going to be to figure out why is the resident falling. Next slide, please. One of the things that we identified early on in the program is that we may be having faulty assessment and incorrect identification at preventing the fall. My entire history and the way long-term care profession has been geared and focused on preventing falls is the following. We have believed that when a resident moves, they fall down. Therefore, the primary intervention should be to prevent movement and mobility, and then you prevent the fall. Let's relook at those interventions. Put them near the nurses' station so that we can watch them and prevent them from moving. So that if they get up, we immediately go in there and prevent that movement. For the first 20, 25 years of my career, we tied residents up. I remember being a night nurse, and every resident, pretty much every resident at night was tied to the bed frame, to their chair. I know that there are nurses out there that remember that we used to tie residents to the commode or the toilet because our entire focus was prevent movement and you prevent a fall. Therein lies the root of our errors. Next slide, please. We need to improve the assessment and look at the correct root causes to preventing falls. And here's what we discovered. A resident has needs, and their needs set them into moving. And because they are weak, they fall down. So if we truly want to look at a new management on fall prevention, we need to address the residents' needs. What is their need that sets them off into motion? What do they need? Then get them physically active. Prevent immobility. Keep them as physically active as possible. And then we will reduce their fall. I also want to give credit there to the bottom of my slide. I really want to give credit to not preventing falls, promoting function, to Sarah Kagan and her associates who did this investigation. And we relied quite heavily on that excellent research and article that they did. Next slide, please. So who is at risk for falls when they come into our nursing homes? This actually was something that we learned when we attended a national fall prevention convention that was held in Tampa, Florida. It was sponsored by the Veterans Affairs Administration. And, by the way, our VA does an excellent job at researching falls. And they said that, again, looking at the former way that we used to hopefully look at assessment on admission and then change that to a more current way, they said we need to take a look at all of the people coming into our facility and stop what they said was waste of time in assessing their level at risk for falling. Because their claim was, if they are coming into our nursing home, they are already at a very high risk for falling. Next slide, please, slide 10. The claim of this presenter, the VA associate, said, so who is at risk for falling? Let's see who we are admitting to our nursing homes. And what she said was, a person who is at low risk generally are between the ages of 5 and 25. They're physically active, mentally alert, and suffering from few diseases and disabilities. The medium risk person for falling is 25 to 45 years of age. I know some listeners are now groaning. They're less physically active, less mentally alert than the group before them, and they're beginning to experience more diseases and disabilities than the group before them. Who's at high risk for falling? The high-risk fallers are 45 to 65 years old. And those fallers are less physically active than the group before them, less mentally alert than the group before them, and again, they are also suffering from more and more disabilities and diseases, comorbidities. The very high risk for fallers are those people who are over 65 years of age, less physically active and mentally alert than the three groups before them, and they're suffering from more diseases and disabilities. So what this colleague said was, why are we taking so much time to determine risk level on admission? What she said is, they are all at very high risk for falling. But next slide. What she said is what we are deficient in is determining what puts them at a very high risk for falling. She said because that's where we should be putting our energies. Our new management look at falls should not be looking at risk determination. Just put it on the table. Everyone admitted to a long-term care skilled nursing facility is at a very high risk for falling. But why are they at a very high risk? I'd like to share with you that I am at a very high risk for falling. I am over 65 years of age. I suffer from a disease called Meniere's disease. And it's a disease of an inner ear fluid imbalance. And so that puts me at a high risk for falling. But on slide 11, if you look at Mrs. H.G., who is actually my Aunt Helen, who is 88 years old, she was recently admitted to a long-term care nursing facility, Skilled. She's in early stages of Lewy body dementia. Her symptoms are getting worse. So why is she at a very high risk for falling, and why am I at a high risk for falling? How are you going to treat us differently? And here's how I would begin to look at the interventions that would be appropriate because you've looked at the root causes of our falls. My Aunt Helen has Lewy body dementia. That means that she is suffering from auditory visual hallucinations brought on by auditory visual stimulation. So in order to curb or reduce her falls, you need to reduce her hallucinations. But we are causing her hallucinations when we put her in a bed near a nurse's station, the noisiest place in the facility. We are increasing her likelihood of falls when she is in a congregate dining room because it's noisy and it's scary. And when we put a clock up at the foot of her bed to try to keep her oriented to time, it scares her when she sees the face of that clock. So an intervention to reduce my Aunt Helen's high risk for falling is to reduce auditory visual stimulation. Put her in a quiet room away from the nurse's station. Allow her one-on-one meals. She's really not appropriate for bingo, B29, G30. It startles her. It scares her. And so for somebody who is hallucinating because of visual auditory stimulation, bingo is not appropriate. So we need to look at a new management way of looking at her is to say perhaps hand massage. Find out from my family what does she like as far as music, soft. What does she like as far as reading? Does she like Bible reading, poetry reading? And so you're going to treat her differently than you would me. I've got thickened inner ear fluid, and that puts me at risk for falling. And I'm going to share with you, a low bed is not going to thin out that fluid, and an alarm is not going to thin out that fluid. What is going to thin out that fluid? My diet and fluid intake. I need to be on a low-salt diet, and I need to take my medications every morning for my Meniere's disease. That will assist me from not falling. And so that's the purpose of our program, was to really delve into the root causes, next slide please, of why people are falling. So that on admission, we can now document everyone is at a high risk for falling. This resident, Ms. Guildermann, is at a high risk for falling because of her age and her Meniere's disease. And then identify specific factors that put me at a high risk. What puts me at a high risk for falling? A sudden change in position. Going from lying down to sitting up, my head spins. From sitting to standing, I suffer from that vertigo. And so the specific intervention for me is going to be staff and physical therapy who work so that I can remember to sit, count to 4, stay off the floor. Stand up, count to 4, stay off the floor before I do movement. And it has been the physical therapist who have assisted me. But I dare say, if I go into your nursing home with this history, am I going to be put at the nurse's station? Am I going to have an alarm on? Am I going to be given gripper socks? Because that's not going to thin out the middle fluid of my inner ear. Next slide, please. The next slide I really just offer you as a suggestion. So what can you do on admission generally to keep people safe? And so through our many focus groups, we brought people together to really say, so if the nurse's station and a low bed and a mat and a tilt cushion and gripper socks are not going to keep them safe on admission because we don't know very much about them, what would keep them safe? And so I offer slide 13 as suggestions on admission what would keep people safe. And that number one is key. Careful orientation to room, their apartment, if it's going into AL, and the routines of the facility. And I've often thought that one of the questions that we ought to be asking every resident on admission or their family, if they're not cognitively aware, is what side of the bed do you usually get out of when you're sleeping in your bed at night? All human beings get out of the same side of the bed, and we enter the same side of the bed. So when you or they are lying in bed, do you get out the left side or the right side? And then what we need to do is set up their bed area, their bedroom, to match and facilitate their usual routine at home, getting out the left side or the right side. If I get out the right side of my bed, which I do all the time, and you put me in a two-bedded room and I exit the right side and I exit into a privacy curtain, you are going to facilitate me falling. So where it says that next bullet point, create a room that most closely represents the client's previous home environment, that's what I'm talking about. A previous home environment where I want my nightstand on my right side of my bed, and I want my eyeglasses on top of my nightstand. And in that first drawer of that nightstand, I have my personal items that's how we set it up, to be personal and representative of their home. Next slide, please. So let's look at and focus on root cause analysis. That really is the focus of this 3-year program. How can we delve into and determine why residents are falling in nursing homes? Just ever so briefly, root cause analysis is a process to investigate what happened, why did it happen, and to determine what can be done to prevent it from happening again. Next slide. Root cause analysis, we're really looking at improving the operations of our facility through root cause. And we find that that is much more effective than just treating the symptoms of the problem. Problems are best solved by eliminating and correcting the causes of the problems, rather than merely addressing it through a scattergun approach. And I can remember being that director of nursing, thinking, okay, I've put 5 interventions in place in 2 days since this gentleman came into my facility who I determined as being at high risk. Please, God, let one of those interventions work. That's a scattergun approach. I don't know which one is going to work. I just hope one of them will. And that's what we're saying, no. We really need to be more judicious in our focus on, next slide please, 16, what specifically contributed to that resident falling at that time of the day, that day of the week in that nursing home. And so we were taught by Dr. Dan Sheridan, a national forensic research pathologist, and he came and he taught us how to investigate. And one of his first suggestions were to investigate 3 conditions at the time of the fall. What is the internal condition of the resident at the time of the fall? What is the external environmental condition of the area in which they fell? And operationally, what's going on in that nursing home that they fell today? One of the ways he said to consider it is, how come that resident didn't fall yesterday at this time? How come they fell today? Today is Thursday, and it's 1:29 in the afternoon. And I hope it doesn't happen, but somebody's going to fall in one of your nursing homes within the next few minutes. Why did they fall at this minute? Why did they fall on this day? Why didn't they fall yesterday at this time? Because you were doing something different operationally in your facility yesterday. Or perhaps they were started on a new medication this morning. Or perhaps their personal care attendant, who they really trust and like, called in sick today. But something changed in their environment, internally or operationally, that they fell today. And that's what Dan Sheridan said. We've got to begin by looking at those three primary conditions that contribute to it. Next slide, please. Slide 17 is really that look at moving falls and managing falls differently than we have in the past. Let's move falls into the clinical area of assessment, cause, and treatment. Over the years, we have improved significantly in managing and assisting our residents in being less incontinent. We've done a wonderful job at learning how to assess for incontinence. Is that incontinence the result of a urinary tract infection? Is the incontinence a result of a neurogenic bladder and what's causing that bladder to be a neurogenic bladder? Do we have a hyperactive bladder? And if so, why is it hyperactive? Or perhaps the person has prostate cancer, and that's impacting their ability to be continent. And so over the years, we've looked at assessing continence, looking for its cause, and then looking for the treatment. I am not going to treat a woman with UTI the same way I will treat a woman who has a very flaccid bladder. Pain. Again, we look at pain, and years ago when I started, I can remember just having a physician order that said, well, start with 2 Tylenol. And if that doesn't relieve the pain, then give 2 extra strength Tylenol. And if that's, and so we would simply build on more pain, analgesic treatment. That's not how we approach pain anymore. We look at the underlying assessed causes of pain. Is this a root canal? So we're looking at a nerve pain, or is this pain from sleeping uncomfortably at night on a hard surface? Or did I fall and bruise myself? Or is it emotional pain because of the death of a loved one? What is the underlying cause of the pain? I will not give the same analgesic pain relief to somebody with muscular pain as I would with nerve pain. That's what we need to do with falls. Now we need to move falls into that same sphere and say, what are the causes, the underlying causes of those falls? And only then will we look at the treatments and interventions. Next slide, please. Slide 18 says, care plan according to the assessed and identified causes and conditions of the fall. What is the disorder? I have Meniere's disease. What is the outcome of that disorder? I suffer from vertigo. What are the symptoms of my disease? Severe dizziness on change of position. However, I do need to move. And what are my vital signs? Sometimes patients fall because they suffer from orthostatic blood pressure brought on by the side effects of medications and the interaction of medications that we're giving them. And so we need to look at our care plans where we carefully say that Sue Ann is at a risk for falling due to her Meniere's disease and vertigo. And then we walk across that care plan with the intervention that is appropriate to the causation. Next slide, please. What you're looking at slide 19 are 2 people who apparently fell. They fell on ice. My first reaction is, what were they doing on the ice? But okay. My next reaction is, why did they fall on the ice? Because we've got 4 people who are standing upright, 2 people who are helping the fallen victims. So my first reaction is, so why did they fall? What was the underlying causation of their fall? Did they not walk correctly? Did they walk too quickly? Was their foot gear not appropriate? So what caused 2 of these 6 people to fall? Next slide. While this person may look like, slide 20, that they're sunbathing, they actually fell. Why did they fall? Heat? Dehydration? What was the cause of their fall? Their footwear looks excellent. So I'm going to do just a quick visual here and say, I don't think it's inappropriate footwear. Did they trip over something on the bridge? Why did this person fall? Next slide, 21. What of our residents who actually fell? And this is a reenactment of that fall. Why did they fall? Many of you might notice that we've got a shoe that's untied. They're on a carpeted surface. What did they fall on? That's actually a wheelchair scale. Did they trip over the scale? And I hope some of you have noticed that at the end of the shaft of that walker, it has broken through the tennis ball. And so, the causation, primarily the causation, there's never only one cause, there's usually a number of causes. The primary cause of this fall was inappropriate maintenance of a walker with tennis balls that broke through and caused that shaft to stick on the carpet, and the resident fell down. So if we look at these three fall events, the first person who fell on the ice, perhaps it was because they were walking too quickly. And that second person might be dehydrated, so they need more water. So now I look at this third person and I say, well, if that's the case, let's change up the footwear and give her more water. But no, that's not appropriate, because she has a different cause for her fall. Next slide, please. So I would not use the same interventions for each of their falls. But I need to share with you that 20 years ago, if any of these people were on their way into my facility, I would have assessed them as being a high risk for falls, and I would have started the whole ball rolling. Get them near a nursing station, put them in a low bed, put them out on the floor, put them with a restraint. Oh, can't use restraint. Put an alarm on them. And I would never have addressed and reduced their falls because I did not focus on the causation. Next slide, please. I know a couple of people have said to me over the years, but why do you spend so much time looking at one fall? It's a single event. That person will never fall that way again. And my answer to that always is, why do we look at any accident or event? Around, the early 200s, 2000, around 2002, I believe, there was a car being manufactured where the brakes were consistently failing. And initially, the car manufacturer said, well, that's because the drivers were going too fast. Or that's because of the weather conditions. And it wasn't until all of these accidents began to be recorded and a consistent pattern began to show up, where people said, well, we're driving in all kinds of weather. And these accidents are occurring in all different countries, on different road surfaces, at different times of the day, and yet the brakes are still failing. And so because they were able to identify a pattern, they were able to identify the underlying root cause that the brakes had been installed incorrectly. And that's what we did in our program. In our program, what we were able to do, next slide please, slide 24, what we were able to do is, with the monies we received, the fundings we received from the Department of Human Services, we were able to hire and design a software program. And I just want to digress here for just a moment so people understand where we're getting all this information. In our program, when a resident falls, a post-fall investigation will be done, and I'll show you that in more specifics in a moment. But once a week, our facility had an appointed, every facility in this program has a fall risk coordinator. And that fall risk coordinator would once a week batch all of those post-fall investigations and send it electronically over the internet to Impera. And at Impera, at our office, at our headquarters, we would put it into, we would upload it into our software program. And our software program began to assess the data that we were receiving from all of our facilities. And so as the weeks and months progressed, our software began to show us that every single facility in the program seemed to be having falls occurring pretty much at the same time. We were able, through our software data that was collating and aggregating and trending all of the reports that were put into it, it was able to show us trends and patterns. What days of the week do residents fall? Is there a more popular, if you will, fall day in a facility? Is there a more popular time? What about a place? In their room, in the hall, in congregate areas? And what was the resident trying to do just before they fell? What was the need that set them into motion that because they were weak caused them to fall down? We really needed to get at that need and identify what was it. And so our software program did it. But it started with this slide, 24. The first step was we had to determine what happened by getting to that resident, staying with that resident, and gathering the clues and evidence through observation, examination, interviews, and assessment. And all staff were taught to do this. Housekeeping staff, maintenance, dietary, social service. All staff were taught to go to the resident, stay with the resident, and we taught them the clues to look for, those external, internal, and operational clues at the time of the fall. Once we gathered the clues, then we started to look at the why. Why did this happen? What conditions allowed this resident to fall down? We investigated, we assessed and deduced. We began to, as a group, determine the root causes and the reasons for why this fall happened at this day at this time. And only then did we move to the third step. Implement corrective actions and interventions. See, that's what we did. We flipped the practice of nursing home and fall prevention. We didn't put the interventions in place immediately. We looked at the underlying causes. Next slide, please. So what slide 25 is showing you is that observation skills are critical. And it's so easy to miss something you're not looking for when we're so task-oriented. As a nurse, I was so task-oriented passing my medications that I hardly ever looked at the roommate who I didn't give the med to. Because I was watching this resident swallow her med, not pocket it in her cheek, make sure she took it. I hardly looked at her roommate, and sure enough, I walk out of the room, and 2 minutes later, the roommate fell on the floor because I was task-oriented. And so we really encouraged all of our staff to look, just look at the resident. Look, listen, question, and really engage, even if it's for a few seconds, an interaction with that resident, and that went for all staff. Once the resident did fall, we would immediately protect the area, and we would secure it and encourage the resident not to move and not touch anything so that we could start to look at, did the resident trip over that wheelchair scale, or did she fall onto that wheelchair scale? I have shown that previous picture to many people, and an audience will say, oh, she must have tripped over the scale. And I'll say, look again. What's laying on the scale? Her shoulder, not her feet. And so by not disturbing that scene, we were able to get to the root cause. And I'll be honest, for years, as a nurse being called to a scene where a resident has fallen, the first thing I would have done is straighten that walker, because I have to take her blood pressure. And I've got to do neuro checks, so get that walker out of the way. And I would have disturbed the clue that that tennis ball had been disturbed, broken through, and I would have missed the clues. Next slide, please. This is one that we were taught by Dr. Molly Moran at a conference, and she, again, was another supporter of root cause, looking first at the causation of the fall before you put an intervention in place. And these really are her suggestions. She was one of the first people that we heard years ago say, what was the resident doing or trying to do just before they fell? Because that was their internal need that drove them to fell. And then she said, all staff need to learn that where the fall occurs can frequently tell you why the fall occurred. And she said, for instance, it had been her experience, and by the way, she was a federal CMS investigator, and she would go into facilities investigating incidents and accidents that had been reported up to the federal level. And so what she was explaining was, she noted that when residents fell right next to the transfer surface, let's say it was the bed, the commode, the chair, the toilet, if they're found right next to it, Most of the time, that was due to orthostatic blood pressure, which means that they stood up, blood did not pump up to their brain, and they fell down. And she said, so you could be pretty certain if they're laying right next to that bed, that's orthostatic blood pressure. And she said the primary cause of orthostatic blood pressure is medications, medications, medications. 5 feet away, she said invariably that's balance. If they lost their balance 15 feet away, they didn't have the strength or endurance to continue to walk. And then lastly, she said, always check if they're in the bathroom or near the bathroom, the contents of the toilet, as that can be indicative of why they fell. The clues are in the toilet. Next slide, please, 27. So with only 15 minutes left, I'm going to go rather rapidly through these remaining slides, just to let you know what we looked at. Our software, we would put into our software program the medications that residents were on. We looked at, were they wandering or pacing at the time of the fall? Were they grabbing or pushing? What was their cognitive status? Next slide, 28. What our software program identified for us within just a couple of months of the program is that the 4 primary needs of a resident, when they were asked, what were you trying to do at the time just before you fell? The 4 primary needs that our residents indicated were they just wanted to change their position. They'd been sitting, laying too long, and they just wanted to move. I interpret that as boredom. They're just bored. They just want to move. And these are all I want to share. Number 1 answers. There's not a 1, 2, 3, 4 here. The next one was they had to go to the bathroom. They had to urinate. The third one was they changed their position because they were in pain or they were uncomfortable or they ached. And then the fourth one was they were looking for something that wasn't there. They couldn't find their personal item. It was out of reach or misplaced or not where they were used to it. Slide 29, that shows you exactly how I would recommend implementing this program. Start by teaching root cause analysis. And each of my subsequent slides is going to support each of these bullet points. But just briefly, let me go through the bullet points. Number 1, when a resident falls, all staff must be educated in the check, call, care system. Next, they must be prepared to have on their body somewhere a small laminated business-sized card, and frequently in my nursing homes, because I've got many of them, they'll put it on the back of their name tag. But they need to take out these 10 questions and start looking. What the 10 questions does is it assists them in looking for the clues to determine why they fell down. The nurse must arrive and do a nurse assessment. We do a post-fall huddle after the fall with staff to identify, what do you think? What clue? Well, you were in there 2 hours ago cleaning their room. What did you notice? You gave them AM care, PM. What did you notice? And so you gather people together ever so briefly, 5 minutes, just to say, got any ideas? Did you notice something different today than yesterday? And then all of that is put into our fall scene investigation. Our post-fall investigation form is called our SSI report. And then that report, plus their most recent MDS, goes to the fall committee meeting. So now what I will do is literally go through each slide that supports each of those conditions. So the next slide, please. Slide 30 is check, call, care. The best practice that I've seen, many of my administrators have laminated just this slide, and this slide goes on medication carts, it's in activity rooms, it's in the dietary kitchen, and it says to the staff, this is what you must do when a resident falls. You go to them, you stay with them, you summon a nurse, you encourage them, so please don't move, are you okay? A nurse is on the way. And then in a conversational tone, just ask, what were you trying to do just before you fell? Get at your 10 questions. Are they in your pocket? Are they on the back of your name tag? And start delving into answering those questions. Stay for a huddle and assist in the huddle. The next slide is the 10 questions. I know people often will say to me, well, do you have a copy of the 10 questions? Yes, we do. There are the 10 questions. And without going through each one, you have them. Those are the 10 questions that have been simplified down into a business-sized card. Next slide, please. Slide 32 shows you the nurse assessment. We've been doing this for decades, and we've been doing it right. When a nurse gets there, a nurse needs to assess for vital signs, pain, neuro checks. When you get back to the nurse's station, take a look at recent lab results. My one cautionary note here, medications. We focus well and do well on listing the meds they're on, but what are the side effects of meds? Nurses nationally test out very well on knowing the actions of meds, but we don't know the interactions of meds very well. And I would recommend looking at that. Diagnoses. Until my Aunt Helen got Lewy body dementia, which was only 4 years ago, I have to be honest with you, I didn't know that one of the symptoms of Lewy body dementia was auditory visual hallucinations. And over the years, I have taken care of many patients with Lewy body, and I'll bet you I put alarms on them, and I put them near nurses' stations because I had knowledge deficit. To my colleagues who are nurses, please go back and look at that diagnosis. Did you know the difference between macular degeneration and cataracts and glaucoma? Because each one of those are eye conditions, but they're very different, and they have different causes, and they have very startlingly different interventions. Next slide, please. Fall huddle, that shows you how to do a fall huddle. Next one, slide 34, tells you how sometimes we may need to reenact the fall. The next slide is that fall team investigation form. You can get a copy of that from Stratus. That is the form that is completed and sent into our software program. Next slide, please. What you're looking at is our fall committee. Our fall committee generally meets now once a month. That is the entire agenda. So you have the agenda there for the fall committee meeting. You have the purpose, the goals, and who should attend the meeting. And then slide 27. Really, I'm wrapping up now and looking at the summary of our program. Our program is different because we looked at the reasons for resident falls. External, internal, and systemic causes of the falls. Why? Here were our findings. Slide 38. Primarily, what we discovered through our software assessment is that the primary external causes of falls in nursing homes in the United States today, the external cause is noise. That shocked us, that surprised us, and we didn't see that one coming. Busy activity, lack of environmental contrast. We lose depth perception as we age, and so having that lovely beige carpet against a beige wall with a beige privacy curtain is doing nothing to assist in depth perception. As we age, we need contrast in color and intensity in our environment. Placement of personal items and furniture. We neglected to put things where residents expected them to be. And what you're looking at is the descending order of what we found. Next, the primary internal causation of falls. Poor balance and immobility, which were directly a causation of our keeping them immobile in tilt cushions. Next, sleep disturbance and fragmentation. We didn't even know about this when we started our program, and it then led to our next 3-year grant that followed this program. The primary internal systemic generic condition that causes residents to fall is sleep fragmentation, that we continually disturb their sleep and they have a poor quality of sleep. I'll digress for 1 second here and ask everyone listening, if I woke you up every 2 hours, every night for the next 6 weeks, heck, let's make it the next 6 months, would you be able to balance? How would it affect your cognitive ability? How would it affect your ability to have strength to move? You know that on an extremely uncomfortable, sleep-disrupted night, you go to work and you can hardly function. And there are some of you listening to me right now that had very poor sleep last night and you're hardly staying awake as I drone on about this fall management program. And yet if you had had a good night's sleep last night, you're more attentive and you're taking notes and you're paying attention. And so here I am in an industry where I'm providing care with residents, and the primary care I never concerned myself with was their quality of sleep. And this program drove all of us, all of my colleagues at Impura, to look at sleep and the fact that we were fragmenting their sleep. And we were doing so because we just followed a standard of care of turn and reposition every 2 hours. And so we challenged that standard of care. And we said we've got to get them to sleep and allow them to sleep undisturbed throughout the night without having their skin break down, without having them be incontinent. And so we were able to do that in the subsequent program that followed this one. We went back to the government and we asked for another 3-year grant to allow us to assist our residents in sleeping undisturbed throughout the night. And it was phenomenal. The effects of that program, I think, have had absolutely the greatest positive effect on residents' care. Next slide, please. What you're seeing is just now the summary. If we can stop the noise, we can reduce the falls. Next slide. If we can stop disturbing sleep, then we can reduce the falls. And system-wise, operations and management of systems is what contributes to falls. What are your corporate policies and procedures that you have in place that might be actually helping them to fall? For instance, giving meds every 4 hours. Really? You need to wake them up in the middle of the night to give a medication? Couldn't we give that med at a different time? With a mattress that has no pressure points, pressure-reducing mattresses, pressure-less mattresses, a resident does not need to move and turn as often. Hydration, predominantly offered and encouraged in the early morning hours, and a tapering of fluids after dinner, so that after dinner you have little to no fluid intake. Of course, this depends on the assessment and their medical condition, but nevertheless, if you reduce fluid after that evening meal, you'll reduce nocturia, nighttime incontinence. And that's a policy and procedure that we had to look at and say, okay, did we contribute to it? So next, the ending of this entire presentation are the interventions. Now you see our program. Now you see what we did. We investigated the falls. And so those were the internal, external, and systemic causation of falls. The interventions we ultimately put into place were totally dependent on what did we find was the cause of that resident's fall. If a resident fell because they were out in the middle of the hallway and they were 30 feet away from their bed, well, that would perhaps indicate strength and endurance. And so putting gripper socks on them or having somebody assist them might facilitate that if the floor surface is correct. But I'm not going to put a gripper sock on somebody who's walking on carpet. But I would put that gripper sock on them if it is a linoleum or tiled floor. Again, I'm looking at causation. So interventions. Really, the key to the intervention on that slide 42 is interventions must match the causative agents of the condition. Next slide, please. This, again, builds on interventions. What will you do to prevent this fall from happening again? It was a Tuesday at 2 in the afternoon. They were on their way to the bathroom. What was going on that caused that fall that you'll prevent it from happening? Next one. Next slide, please, 44. Noise. We looked at where was the noise coming from. We identified that personal alarms, slide 45, next slide, was the primary causation. At first, we identified as a correlation that, well, that's coincidentally interesting that they seem to be fumbling when you put an alarm on them. And, oh, is this a coincidence that the roommate is falling of the person who's sharing the room who has an alarm on? Oh, is that coincidental? No. over the years and ensuing, months and ensuing years, we identified that alarms, noise caused the fall. So we are currently an alarm-free nursing homes. We don't use alarms. And then I see I have 1 minute left, Christy. And so to push on through, slides 48, 49, and 50 are ways in which we contrasted our environment. Slides 51 and 52 talked about mats on the floor. We've reduced and all but eliminated mats on the floor. We, and by the way, I do cite the Veterans Administration there, have identified mats. And you really need to look at a risk-benefit there. They are a trip hazard. They do cause an unbalanced surface for residents. The next slide, 53, is hip protectors. If residents are at risk for rolling out of bed, and they really don't roll out of bed, they're trying to get out of bed, and instead of a mat on the floor, they should be wearing hip protectors. The slide 54 shows you the hip protectors that went through rigorous government investigation, that Veterans Affairs article that I cited 2 slides back. This is what they identified as the top performing hip protectors that actually do reduce injury. And then the rest of my slides, as you go through them, you'll see we looked at medications, slide 56, slide 57. We really put balanced programs into place, slide 58 and 59. And then the summary again, slide 59, 60, 61, and 62 are the summaries. And then 64, my very last slide, again, what are the strong interventions I would recommend to prevent falls? Look at matching the intervention to the cause, learn root cause analysis, and there, as that slide progresses, it shows you which of the interventions we found to be most effective. And that is my story, and I'm sticking to it. I think I'm 1 minute overtime.
Oh, great. Thank you, Sue Ann. I know that was a lot of information, and I know we don't have time for questions, but we really appreciate all the great ideas that you've given us. This last slide is just a slide about the National Nursing Home Quality Care Collaborative change package. Hopefully a lot of you are aware of it, and it's just a reminder that there are a lot of great tips in there to help you as you work to improve the quality of life and the quality of care of nursing home residents. We don't have, as I said, we don't really have time for questions, but I do want everybody to know that as you exit from this webinar, a window is going to open for a short evaluation. I've also put the link to the evaluation in the chat box. Please take a minute to provide feedback on today's session, and know that once you've completed the evaluation, you're going to get a certificate with CE credit. So you will get CEUs for this particular presentation. So make sure you fill out that evaluation. That's all. Our time is up. And again, Sue Ann, this is very, very valuable information. I'm really glad you shared it with us. So many of our homes, falls is the #1 thing that we're working on. So I think this is very helpful and gives us all food for thought. Just so everyone knows, this session was recorded, and it will be available on the Lake Superior QIN YouTube channel in a couple of weeks. And if you're looking for it, if you connect with the QIN in your state, your contact, I'm sure they'll be able to help you find that. And that concludes our session today. Thank you again.
Thank you. And a shout out to my SOS leaders. Thanks. Bye-bye.
Ladies and gentlemen, this concludes today's conference. We thank you for participating.